Okay. Now coming to what is null zone. Null zone, it is very important. This is the position in which nystagmus is minimal, and patient adopts head position to keep eyes in this null zone. And in surgical management of nystagmus, the null zone is centered. Okay, just remember this much. And now we will see what are the causes for nystagmus. Okay, so etiologically, we can classify nystagmus as physiological nystagmus and pathological nystagmus. Okay, physiological nystagmus means it's a function of the normal oculomotor nerve and the system. So it is normal. It is normal in normal people. Okay, so it is the important varieties are optokinetic nystagmus, endpoint nystagmus, and physiological vestibular nystagmus. And all these are pathological nystagmus. Coming to physiological nystagmus, the most important varieties are physiological vestibular nystagmus or vestibulo-ocular reflex. It is the reflexive movement of the eye that keeps the visual image stable on the retina during brief high-frequency rotation of the head. You remember the cows, no? Cold opposite, warm same side, caloric test. We studied in END. So this is more concerned with END people. For us, optokinetic nystagmus is very important, and also endpoint nystagmus. Coming to optokinetic nystagmus, this is the physiologic movement of the eye in response to large moving visual field. You can observe this in your co-passenger of in a railway journey. Okay, so this is there is a smooth pursuit followed by corrective saccade, and we can use this OKN drum to test this, especially in case of visual acuity testing in preverbal children and test for malingering. So this is normal. Okay, OKN is normal. Now coming to pathological nystagmus. Depending on the age of onset, it can be early onset or childhood nystagmus, or acquired nystagmus or adult onset. Early onset nystagmus, we have infantile idiopathic nystagmus or congenital motor nystagmus. Then sensory nystagmus, latent nystagmus, and spasmus nutans. Latent nystagmus you have already seen. Now coming to the first variety, that is the infantile idiopathic nystagmus or congenital motor nystagmus. This is the most common type we see in children. It is idiopathic. There is no causative abnormality. And character is, it is horizontal pendular in all directions of gaze. There is null zone. So the patient will adopt head position. Oscillopsia is absent here. Convergence and sleep abolishes nystagmus. So you can just remember this mnemonic: congenital, convergence and eye closure dampen nystagmus, oscillopsia is absent, null zone is present. It is horizontal direction nystagmus, pendular, near visual acuity is good. Inversion of OKN is present here. Another character is inversion of OKN, and it abolishes in sleep. Okay. Now coming to the next variety, congenital sensory nystagmus. From the term itself, you know, there is some problem with the sensory pathway. There is sensory deprivation. Nystagmus developing as a result of that. Seen in bilateral mediopacities, congenital cataract, bilateral retinal diseases like retinocoloboma, then bilateral optic nerve abnormalities like optic nerve hypoplasia, optic atrophy, coloboma, and also in albinism. So you have seen albin children, and they are having congenital sensory nystagmus. Now coming to the very interesting variety, this is the spasmus nutans. This is a triad of binocular small amplitude pendular nystagmus associated with the head nodding and abnormal head posture or torticollis. Okay, this manifests at first year of life and resolves by first decade, and usually benign condition, but there will be some reduced visual acuity. Regarding nystagmus of childhood, always think of another important life-threatening DD, that is gliomas. So before you say, this is normal, it's okay, you just order for a neuroimaging, that will be safe. Can I have 2 more minutes? Now, Now coming to, very sorry. Okay, now coming to pathological adult onset acquired nystagmus. we can just pass through the important ones. One is peripheral nystagmus or vestibular nystagmus. Peripheral vestibular nystagmus, central nystagmus, and the special types of nystagmus. Peripheral nystagmus means this is as a result of disease of vestibular organ. Okay, like labyrinthitis, Meniere's disease, drugs, and it is associated with a severe vertigo. Maybe there will be vomiting and hearing loss. And the character of nystagmus is mixed here. There will be horizontal nystagmus with some torsional components. And the nystagmus is when the patient is looking away from the side of lesion. And visual fixation will dampen this nystagmus, and there is fatigability. That is, on repeated testing, this nystagmus will decrease. Okay, that is peripheral nystagmus for ENT people. Okay, now coming to central nystagmus, this is as a result of disease of the CNS, either brainstem or cerebellum or its connection with the vestibular apparatus. So this is associated with just mild vertigo, and the associated findings are long tract signs and cranial nerve signs. This is central nystagmus, and the character is classically purely horizontal or purely vertical or purely torsional. Okay, just differentiate it from peripheral nystagmus. Then nystagmus is more towards the side of lesion, and there is no change of nystagmus with fixation, and there is no fatigability. Hope you understood that. Now coming to gaze-evoked nystagmus. This is again a jerky nystagmus in lateral gaze or up gaze. Obeys Alexander's law. Alexander's law is nystagmus increases in amplitude and frequency as the patient looks in the direction of fast phase, and these are the causes. Coming to special types of nystagmus, you have seen this patient, isn't it? This is a very classical Brunn's nystagmus. Okay, this is a bilateral nystagmus with a combination of slow, large amplitude nystagmus towards the side of lesion and rapid, small amplitude nystagmus away from the side of lesion. This is large amplitude, slow nystagmus to that side, and rapid, small amplitude nystagmus away from the side of lesion. This is classical of CP angle tumor and meningioma. That is Brunn's nystagmus. Now coming to upbeat and downbeat nystagmus. Upbeat nystagmus is seen in posterior fossa lesion. You can see that the fast component is towards upside, and cerebellar vermis lesions. Downbeat is just opposite, seen in Chiari malformation, cervicomedullary junction lesions, cerebellar flocculus lesions. Now coming to next interesting variety, that is seesaw nystagmus. This is again a pendular nystagmus. This is one of the questions in today's case. Seesaw nystagmus you will see in suprasellar and parasellar mass lesions, craniopharyngioma. There is intorsion of the elevating eye and extorsion of the descending eye. Okay, it's a pendular nystagmus with intorsion of elevating eye and extorsion of descending eye. Now coming to convergence retraction nystagmus. This is also very interesting. This is typically seen in Perinaud syndrome, the dorsal midbrain syndrome, and you know the features of it. There will be vertical gaze palsy, light near dissociation, and convergence retraction nystagmus. You can just observe that there is vertical gaze palsy, and on up gaze, on attempted at gaze, there is convergence of the globe, retraction of the globe, and there is nystagmus. Then coming to abduction nystagmus. This also we come across in internuclear ophthalmoplegia. This is a dissociated nystagmus. This right eye, it is going for nystagmus. Left eye, lack of adduction. And now left eye is showing nystagmus, and there is lack of adduction in the other eye. This is actually a bilateral internuclear ophthalmoplegia, otherwise called Webino, wall-eyed internuclear ophthalmoplegia, very classical finding. On the side of lesion, adduction is limited, and the normal side will go for abduction, and there will be nystagmus. That is the abduction nystagmus. And the treatment options, we have all these options. That is beyond the scope of this discussion. And thank you for the patient hearing. Thank you. Thank you.
Thank you, Dr. Sinu. Now next we go on to our next speaker, Dr. Thomas Arun Varghese. He is a glaucoma and neuroophthalmology consultant. His favorite subject is now neuroophthalmology. He is now consultant at Jacob's Eye Hospital, Alphonse Eye Hospital, Pala and Todupuzha, St. Joseph's Hospital, Kadirapalli. He has immense experience in glaucoma and neuroophthalmology. He won Best Paper Synapse Neuroophthalmology Conference in 2016. and he is a speaker and our old quiz master at KSOS. Over to Arun.
Thank you very much, Dr. Maliga, for this opportunity. My talk will be mainly a clinical-based talk, may not be that much exam-oriented, but hopefully it will be useful for you even after your exams. So double vision, the where and the why of the double vision, the cause can be in the eye, the orbit, the extraocular muscle, the neuromuscular junction, oculomotor nerves, or the brain, and the what. It can be ischemic, a tumor, aneurysm, myasthenia, caroticocavernous fistula, thyroid-associated ophthalmopathy, autoimmune, trauma, giant cell arteritis. This is not an exhaustive list, but these are the common causes that we see. So just like in neuro-ophthalmology, history is very important. So history, again, helps in the localization. You can have a sudden sixth nerve palsy. Sudden onset means it is probably a vascular lesion. So the etiology, big clues you get from the history, and again the localization with your examination. And where necessary, you need to use the appropriate investigation in order not to miss a serious lesion. History, Dr. Sinimol gave the talk on the last case that she showed of internuclear ophthalmoplegia. So the patient says, gives very important clues. Typically, patients with INO, they will say they have double vision when they are trying to read. So that is because they are not able to adduct. But equally, a patient with a mild sixth nerve palsy, they will say they get double vision when they're looking in the distance. So all these are very important, give you important clues, and these clues will help you in coming to the diagnosis. Of course, most important thing, the first question you ask is whether it is uniocular or binocular, because then your approach is totally different in either of these cases. You also ask for associated symptoms, of course, any history of numbness, weakness, any history of trauma, surgery, diabetes, all the vascular risk factors, and also a brief examination, skin, CVS, GI, all this history can give you a clue as to the possible diagnosis. Diurnal variation, of course, in the case of myasthenia, but sometimes it can be applicable to other conditions as well. The checklist in the examination, you need to do a brief neurological examination. You can look at of course, in addition to your 3, 4, 6 cranial nerves, look at the lids, the ptosis, extraocular movements, and the pupil, very important, differentiating between a pupil involving, a pupil sparing third nerve palsy, and of course nystagmus, Dr. Sinimol just covered. And then of course corneal and facial sensation. I'll show you with a case how important this is. And something always people talk about myasthenia to do the eyes test. Something I found extremely useful is to check in the orbicularis oculi, and I'll show you that with a few cases. Is really because there are very few conditions where you get double vision or ptosis with weakness of orbicularis oculi, and this really can help you in directing your attention towards possible myasthenia. And a brief neurological examination, you check in the other cranial nerves as well, the 8, 9, 10, 11, 12, all the cranial nerves should be checked. A brief examination of the patient, some things like a scar on the forehead. I'll show you what this meant. And again, scar of herpes zoster ophthalmicus on the forehead. Mild proptosis, you can see with the Napsigus sign. Sometimes a facial palsy may not be that obvious. You can see just an absence of a flattened nasolabial fold. That may be the only indication of an associated facial nerve palsy in a patient with diplopia. So all these can give you clues as to the possible etiology. Site of the lesion, so uniocular diplopia, obviously you're thinking the lesion is in the eye, and sometimes this can be subtle, like an astigmatism, corneal disease, or even cataract, sometimes can be misleading. So typically patients say that when you ask them, the images are unequal, and also the images are usually touching each other, but that is if it is two images, of course. So I'll show you this patient here, previous history of cataract surgery, and she suffered an injury to the eye, and she came with double vision, and the double vision was persistent even on covering the left eye. And this is actually the fundus photo I took of the patient, and you can see the two images of the disc and the fundus. And this clearly showed subluxated IOL causing double vision to the patient and also in the fundus photo. But this patient, she had seen 4 ophthalmologists, 1 neurologist, and 1 psychiatrist. And her complaint was polyopia. So see, how many of you go out and see the full moon I don't know, we don't do these things these days. With all this artificial lighting, it's very difficult to see. But she went out, this is a patient in Pala, and she said she could see 10 moons. So she covered one eye and she could still see 5 moons. So she had seen multiple ophthalmologists, and then they said to send to neurologists, and her family and friends said she probably has a psychiatric problem, and she saw a psychiatrist. And so finally she came and she had cataract surgery, and all the polyopia disappeared. So sometimes this can be very misjudging. Sixth nerve palsy, again, typically sixth nerve palsy, there is maximum deficit at onset, or maybe maximum within 24 hours. So if it is gradually worsening or gradually happening over a few days, it is not ischemic. So maximum deficit is at the onset, and of course typically in a vasculopath. But if anything different from this, you need to think of another cause. So this is a lady, again her complaint was double vision and looking in the distance. You can see it's a very subtle sixth nerve palsy on the left side. But again, I am a clinical person, so anything plus in addition to sixth nerve palsy, of course in a vascular path, but anything plus like a papilledema, any of other cranial nerve involvement, any congestion, you need to think of other causes. Any mild proptosis, and I'll show you examples of this. And I said, if you are thinking somebody with presenting like a sixth nerve with orbicularis oculi weakness, think of myasthenia. So this is the lady I showed you with the scar. So she came with double vision. You can see she has a head turn or face turn, and you can see she's got a congestion in the left eye. And I asked her to look to the right side. You can see the eye does not move, but you see the prominent vessels. And I asked her, what is the scar? She fell off a scooter. Her 14-year-old son was riding the scooter, and she was pillion rider, and she fell off the scooter and had this injury, and these symptoms started about 6 months after the injury. So straight away that scar gave me the clue. You're looking at a carotico-cavernous fistula, and that was the diagnosis. Again, a lady I saw in UK on oral contraceptive pill with an attack of diarrhea. So this led to hypercoagulable state, and she came with double vision, and fundus showed papilledema. So double vision, a sixth nerve palsy with papilledema means raised ICT. So neuroimaging, all cases of papilledema, MRI plus MR venography. And the MR venography showed thrombosis of the superior sagittal sinus. And that means, thrombosis of the superior sagittal sinus. So that this can only be picked up with MR venography. And she had anticoagulant treatment, and that led to resolution of her symptoms. Again, this is the patient I was telling you. She came with complaint of a trivial head injury. She banged her head on a shelf, a trivial injury, and presented with double vision. Actually, when she said she was intermittently, she was seeing things double, horizontally. And when we actually examined it, it looked normal, but because of the horizontal, we were thinking probably sixth nerve. But importantly, we checked the other cranial nerves, and there was some absent sensation of first and second divisions of trigeminal. And that meant she definitely had a lesion, and obviously it was multiple cranial nerve palsy, and she had an acoustic neuroma. So subtle injury, a trivial injury, you should not get misdirected by that. That what happens is in a patient with a mass, and the nerve is getting stretched because of the trivial injury or neuropraxia, and that's caused the symptoms. Of course, in a pediatric case, never a sixth nerve. This is actually the child's father is a photographer, so he took this photograph, mild palsy there, and 1 month later they waited, and this is the photograph, and the patient had a base of skull lesion which caused the tumor. The tumor which caused the double sixth nerve palsy. So approach to sixth nerve palsy patient, I want to spend time. So anything atypical, you need to go for imaging. Third nerve palsy, I'll just briefly run through. So again, the plus symptoms, incomplete or pupil involving, go for imaging. Look for other features. As I said, anything orbicularis weakness, think of other causes. This is a pupil sparing third nerve palsy, diabetic. And this is a pupil involving. This lady is actually post-op cataract patient. She fell off a scooter after coming for follow-up. Fortunately, that surgery was on the left eye, and she fell off and banged this side. And again, the third nerve palsy recovered. It's a traumatic recovered. Fourth nerve, again, I won't spend time on that. Is going into orbital lesions. So you can have restrictive paretic myopathy. I'll just show you a few examples. So this lady, you can see there's some fullness here, no obvious proptosis, but you can see the eye is down and asking her to look up. So this is a tight inferior rectus causing the double vision. And of course, imaging, I won't go into that for lack of time. Last few cases, myasthenia, this is my favorite. So orbicularis oculis, oculi, please check, much easier than doing an eyes test. And I'll show you fatigability, of course, you all know. And this is a patient, actually a husband of an optometrist at Pala. And one day he looked at his wife and said, I'm seeing you double. So this went on for a few days, and then the optometrist brought him. And then you go back and ask symptoms. He said when he's riding the scooter, after some time his hands feel tired. And then this very interesting history is said after walking, then he has to pull his leg up with his hand to put it on the scooter. And then if he's carrying a bag of rice, it tends to fall off. So all these symptoms tells you there is systemic involvement. And of course, in this gentleman also had a CT chest, had a thymoma, and he had surgery, and he's doing very well. Another one was a policeman, and his complaint was again double vision on reading. Very unusual in myasthenia. Again, please check the orbicularis oculi. It is so easy to do. And his symptom was, he said when he's riding the scooter, when he's tired, he's not able to pull doesn't get the force to put the central stand, so he tends to put it on the side stand. And he says, for the last 2 weeks, തോർത്ത് മുഴുവൻ പിഴിയാൻ പറ്റുന്നില്ല. So this subtle history you ask, and he said mug full ആണെങ്കിൽ പിടിക്കാൻ പറ്റില്ല, half ആണെങ്കിൽ കുഴപ്പമില്ല. So all these things tell you very interesting, tell you the systemic involvement, and he had a good outcome. Last two cases, Dr. Mallika.
Yes.
So some myasthenia sometimes does not fit into any particular pattern of your cranial palsy. So sometimes if you have a high suspicion, send it to the physician. Therapeutic trial. You can see here, I really couldn't explain what is going on here. He gave the therapeutic trial, and you can see how he is doing after that. Last patient is a brain of Dr. Sinimol showed this case of INO. His complaint was double vision when reading. So when to suspect a non-ischemic cause, onset if it is gradual or intermittent, think of a non-ischemic cause, more than one cranial involvement, pain, progressing, new symptoms or signs as you are following up and persisting. And of course, don't think it's just yes, this patient has a CPEO, but this patient also has glaucoma. So please, all patients do a comprehensive examination and listen to the complaint, give the clues to the etiology, system review, general inspection, and the great mimic myasthenia, and do appropriate investigations. Thank you.
Thank you, Dr. Arun, for that wonderful presentation. He made all the causes, everything very simple. As he told, cranial nerve palsy, if it is gradual onset, then think of other causes other than vascular causes. Then another associated other cranial nerve involvement with other symptoms or signs, like as he described the condition like that. Okay, now we move on to our last talk in this session, that is imaging in neuro-ophthalmology. Dr. Sujitra has immense collection. She is professor at Namrata Eye Hospital, Kochi, and always it is very difficult for we ophthalmologists to understand imaging. So over to Sujitra.
Thank you. Thank you, Dr. Mallika, for including me in this instruction course. So after detailed history and detailed ocular evaluation, we localize the lesion. Then to confirm, we require imaging. So CT and MRI are the common imaging modality we use in neuro-ophthalmology. So CT scan is based on X-ray attenuation, and here the bone, that is dense tissue, appear brighter, and here there is risk of radiation exposure, and the iodinated contrast material is used. So people who are has allergy, we have to avoid iodinated contrast, and in renal failure also contrast is not indicated.